Welcome, everyone. I'm Saad Omar, and my title for the next 6 weeks is the director of the Yale Institute for Global Health. And I'm also a professor both in the schools of medicine and public health here at Yale, as most of you would know. I'm delighted to welcome you to our last conversation series event for this academic year. As you know, this is the conversation series, Global Health Conversation Series, is run by the Yale Institute for Global Health. But this event is in collaboration with the Yale School School of Public Health, specifically with the epidemiology of microbial diseases seminar series as well. The conversation series is all co-sponsored by the Macmillan Center and their Walker Fund. As we have learned through the COVID-19 pandemic, that health transcends boundaries. Something that emerges in China shows up in Washington, and then within a week and a half in Connecticut, and in many parts of the country and the world. We have also learned that by promoting healthy behaviors, investing in healthcare infrastructure, and specifically with the focus on equity, helps everyone, both domestically and internationally, especially if these lessons are shared. And the beauty of this country's cooperative federalism kind of infrastructure is that we have at least 50 labs. Unfortunately, not all those lab experiments go well, but the idea is that we learn from each other, especially if things are implemented in good faith, with the best possible interpretation of evidence, but also evaluated and shared. So that's the beauty of treating the local health as part of a global whole that we all benefit from. So in today's event, we will discuss these important issues and how global health is essentially derives a lot of its strength for what happens locally. And for our discussion, it is my immense pleasure to welcome two distinguished experts and leaders joining us today. So the first one is Dr. Manisha Juthani. She's one of our own. She's on public service leave from the School of Medicine, and where she's a professor of medicine. Her day job these days is the commissioner of the Connecticut Department of Public Health, a department which was actually owes a lot of its existence and founding to Dr. Winslow, after whom this auditorium is named. And so this institution has a long history of contributing to the state's public health infrastructure. And she's the first Indian American to serve as a commissioner in the state of Connecticut. So again, is a leader from that aspect as well. As we emerge from the pandemic, she obviously helped lead the COVID response, but she continues to focus, and that comes into relief a little bit more, efforts to deal with the other public health issues, including the tragic opioid crisis, lead abatement, gun violence, and especially evidence-based approaches to addressing it, mental health, climate and health. So that's an existential threat we have that transcends boundaries, has global and local implications. Maternal health and drinking water infrastructure improvements are some of the other areas that she's focusing on. She's committed to growing the public health workforce, which y'all are part of the emerging public health workforce. And someone told me there are 40% vacancies are open in the Department of Public Health. Is that
a little bit less than that, but
yeah.
We're hiring.
So exactly, that's the point. And especially those of you who are formatting your CVs for May, and the ones who are graduating, one of the best things to do right after an MPH program is to work for a good, well-run state health department. especially if you don't have to break your lease. And so, that's a pitch of staying engaged, etc., and including those who want to have a subsequent research career as well, and research or a career in medicine. So this is so not just those who wants to, work in a health department for the long term as well. My other guest is Dr. Umair Shah. He's the Secretary of Health for the state of Washington, and he made that trip from Texas. So his training was at Vanderbilt and a few other places, and then was the health commissioner for Harris County around Houston, and led the response both in emergencies and non-emergency sort of healthcare functions for that important, populous, and diverse county in the U.S., and was there when, around Katrina and some other major disasters around Ebola and Zika and sort of all sorts of things that came his way. It was almost like a sandbox video game where things were thrown in his direction, and he came out of that stronger and with several lessons that he took with him to the state of Washington, but beyond as well. He's very active in the National Academies of Medicine. So over his career, he has been a clinician, an innovator, an educator, and a leader in health. He has been particularly a champion of underserved communities, but with a focus of substantive action, not just sort of talking about it, which is important, but taking action. And his career has always been at the intersection of health and healthcare, while charting a fresh course in health by centering cornerstone values of equity, innovation, and engagement. So we are honored to have you both here. And I'll start us off with a few questions for the two of you, and then we'll open it up to the audience. So the first question is actually both of you. And both of you are, to use a military term, war-tested, combat-tested generals in public health. What is the immediate course of action to be taken locally when a global health event occurs? So maybe Dr. Shah, I can start with you, and then with Dr. Juthani.
Well, first of all, thank you, Dr. Umair, for having us as part of this convening, and thank you, Interim Dean Pettigrew and the entire School of Public Health, and just really appreciative of the opportunity to be here. So, I think this is really the defining question. As we are coming out of a pandemic, we see the question for the future about when something happens globally, how do we act locally? And I think this really underscores the intersection of global and domestic health, that we no longer can be thinking about watching something on the news cycle and recognizing that it's over there, because there is no over there. Over there is here. And very quickly, something that can happen in Hartford or New Haven can spread all the way across the globe and flip it around, the bidirectionality of the fact that it can happen elsewhere, and now we're dealing with it here. I always saw with COVID-19 initially when, and obviously, as Dr. Umair said, I was in Houston, I was in Texas, but the state of Washington had the first case, as you know, in the continental United States of COVID-19. We had the first case, we had the first, unfortunately, first outbreak, and we also had the first death. These are milestones. They were unfortunate and sad milestones, but they were also important for the rest of the nation, because what was happening in Washington, people like us, whether it was Connecticut or in Texas, were watching it play out. And what was happening in one part of the nation or one part of the globe, as we were learning of what was happening in, obviously in China, but we were also seeing it spreading through Iran and spreading through Europe and spreading all the way across to other nation states, were important lessons for all of us. And so I'm very used to, in Houston, hurricane lines, all the spaghetti lines you see, there's a storm that's about to hit, you see all these lines. And I remember very early in the pandemic thinking about where is the actual spaghetti line for COVID-19. The first thing that all of us in public health were trying to do was to figure out where are we going to have our first case in our local jurisdiction. And that was, it was really a disease detective case of trying to find that first case. And ultimately, you had the spaghetti lines of hurricanes and storms that were pointing to where it was going to happen across the country, and it just happened to be just north of Seattle. So I think the key question, the real response is that we cannot sit and rest on our laurels when something is happening elsewhere, because ultimately it will impact us locally.
Thank you for the introduction. So great to be here with you, Umair, and all the Yale community that I've been a part of for a long time. I want to make one other plug for the students, which is there is also a Connecticut Department of Public Health Fellowship that people can apply for your summer experiences. I see a few people who maybe know what I'm talking about, but again, this is what gives you experiential learning. You get paid to then be able to enter the public health workforce. So to the point and question about what is global and now local, I want to just highlight even more, when we say local, in the state of Connecticut, we think of the state as local, if you're first thinking about that. But in the state of Connecticut, we have 61 health departments and districts. The city of New Haven has a health department. We, as a state, need to work with our local partners, because that's who's actually on the ground in the community dealing with the health crisis as it's emerging. And so we really have to take local to the really local level, and it's really on us as the state health department to be able to work well. It's been one of my priorities to be able to work well with local health, to be able to execute on these concepts. And what I would say is that, as we've heard, what is global? Global is local. As an ID physician, we were sitting here at Yale New Haven Hospital waiting to see where that first case was going to emerge in the state of Connecticut, as we saw things coming and then to New York and moving up that I-95 corridor and where it was going to happen. So I saw it from the perspective of a practitioner and director of the Yale ID Fellowship Program, and now am at the state level. And the number one thing that I can say is preparedness. It's those preparedness plans. It's going through the exercise and recognizing that any threat can emerge at any time, and you need to be prepared for whatever that might be. You have to have plans in place. They may need to adapt and change depending on the circumstances, but without a plan, it is very hard to execute on that. And we've learned so much from the pandemic, which we have put into place in terms of our plans and preparedness as a state. But without that, you're already behind the 8 ball when something emerges.
So both of you lead sort of the health efforts in diverse states. Connecticut is a little bit more compact. Washington has both just not just diversity in terms of its population, but also worldviews and geography. So from Spokane, etc., on the east to Ferry County, which was Tea Party before there was a Tea Party, to Vashon, Washington, which is the peak of crunchy granola, formerly hippie, currently rich crowd. And
Great place to visit, by the way.
Yeah, wonderful place. The whole state is wonderful. And Yakima County, which is sparsely populated, but reasonably pro-public health. So with that diversity, how do you engage the community? Because it's not one community. How do you work with community leaders? Is there a model to do that? Especially when you can't be the health commissioners for just the conservatives or just the liberals, while being in a democratic society where appointees are political.
Yeah, so first of all, I would be remiss if I did not join my colleague here to remind everybody that we have great internship opportunities as well, great volunteer opportunities. We're a great place to work. We're an incredible state, so please come to the state of Washington. I just want to let people know in this room and beyond, please come, and we are absolutely willing to recruit, and we're not shameless in the process. So I just wanted to make that quick plug. What I would say, a couple of things. So, I came from a deeply different, maybe that's the better way to say it, context, right? The state of Texas is, on the political spectrum, more conservative. It's what we refer to in the popular vernacular of a red state. Then you go to Washington and you've got a blue state. So you got red and blue. What I find, and Dr. Umair, you and I have talked about this, is that you get that diversity everywhere. I'm sure you get that right here 5 minutes from this campus. You may get it right here in this room. Think about that. We assume that everybody has a certain political perspective or a persuasion. That is so inaccurate. And so when I came to Washington, my first comment at my one of my press briefings was to say, I am the state health secretary, not just for one side of Washington, which everybody knows is the I-5 corridor. Everybody thinks of Seattle and just north and just south, where the majority of our population is in the state of Washington. But I am the state health secretary for the entire state of Washington. And then that played out in the midst of our vaccination and our COVID response efforts, that no matter, and our tagline was, no matter who you are, what you look like, where you live, or what you believe in, you should have access to, and fill in the blanks. And that is what health does. It levels and evens out. When there are elected officials and policymakers who are having the partisan discussions, we must rise above that. No matter what, we have to be connecting across the aisle, because our communities are on both sides of that aisle. And shame on us in public health if we're unwilling to do that. And that's where the diversity, not just of the community comes in, but the diversity of us as practitioners comes in as well.
So you are right that there is intellectual diversity in this room. There are indeed 15 shades of woke here, and I'm just joking. There is true. I have found true intellectual, our students here. I'm very proud of the fact that the discussions have been substantive. There have been multiple ways of looking at the world, etc. And so you're absolutely right in that. Coming to the more operational issues. So when you're doing a response, but also more broadly, so the job of a health commissioner or a secretary of health is not just strategic, not just visionary, but also operational. So how do you maintain that logistical resilience, both for the emergency response, but also the other things? People are going to need sort of screenings and referrals and all sorts of other stuff. So how do you operationally manage that? So maybe Dr. Juthani.
So I came into the job as commissioner in the middle of the pandemic. And within a few months of being in the job, Omicron took off. So I came into the job when we were running fast and had to figure out the job and figure out how to do emergency response while at the same time not completely dropping the ball on all the other routine public health types of things that we need to do. And we see the consequences, quite frankly, in our society of the fact that it was difficult to manage social distancing and children being out of school. And we see that impacts of that on mental health, on gun violence, on so many other aspects, maternal mortality, congenital syphilis rates. In Connecticut, we had 8 cases of congenital syphilis in the last year when we had years of none, 0. That is because of a lack of access and accessing of maternal health services for many women. And that's a travesty. We know how to deal with that. That's just regular old public health doing what it does, what medical care when it's running in its usual way in our state really is. So I think for me, we were sort of flying the plane and building it as it was going. You know, so for example, self-test kits were just coming out, and we were trying to buy them and respond to the Omicron wave as it was all happening. And so, you know, now everybody's got more kits than they know what to do with, you know, but that was different back then. Now we're trying to continue to rebuild and maintain that infrastructure on so many of the general public health basic principles that we need to have in place. And it's a different tempo in some ways, but every day there's a new emergency, quite frankly, that comes up. It's just different in scale. There may be a smaller group of people that are affected by that given emergency. It's not maybe the entire state. And I think that I just want to make one comment about, even though we are a blue state, boy, do we have diversity in this state. We have rural areas of this state. We have all the same disparate voices that you see in a red state, and we have the same challenges. Even though we are generally viewed as a pro-public health type of state where people often think people are of the same mindset, that is not the case. And you do have to have an open mind and recognize health as a human right and being able to provide that to everybody and not just those who are the same mindset as you are.
So when you arrived from Texas to Washington, in terms of, you arrived when the vaccine became available, so right around the time.
That same week.
The same week.
Yeah, my wife was not happy with that decision.
And then sort of Washington has done fairly well in terms of equitable distribution of vaccines, in terms of objective metrics, et cetera. Obviously, it took some effort, and all of that. What are some of the approaches, that specific approaches that you applied to make that happen?
Well, that's you know, it's a long, it's a short question, long answer. I'll try to keep it very brief. There were a number of things that we did, and I did arrive the week of vaccines in the state. Fortunately, I arrived in a department that was supported by a governor. I have to be very, very clear. Governor Inslee was a champion for health and continues to be. Many people know him in environmental health and climate change, and the impact on climate on health, but that translated and transferred over to his reading and studying and commenting and being all in when it came to COVID-19 response. And so yes, the first case, first outbreak, first death, and yet you fast forward 2 years later, and or 2+ years later, and we still have the 6th lowest per capita death rate in the nation, and that's quite amazing when you think about all that. So the specific strategies, Dr. Umair, were really very much that it was all in for Washington, that we had to do everything we could. We did the work with our local health jurisdictions. We have 29 officially recognized tribes, so we worked with our tribal leaders. We worked with our faith leaders. We were in communities. We actually, for the first time, had a state asset called Caravan, where we deployed state units that went into communities, 700 of them asked us to come in and help with vaccinations. We had collaboratives for equity, so we had community voice. We also had a public-private partnership. So in the midst of this is really hard for government. Government oftentimes stays on the public sector side, right? So we had our Starbucks, right? We had Amazon, we had Costco, we had Microsoft, we had Gates Foundation, we had Google. I mean, just Alaska Air. We had all of these folks who were saying, what can we do to help? We brought them together. So when Starbucks said to us, the governor asked us, there's a specific example, I want to make sure you're going to stand up 4 mass vaccination sites in the next 48 hours. And we did it, okay? But we stood them up, and we reached out to our private sector partner who were part of our collaborative, and Starbucks said, if we can get a latte in the hands of consumers 35% more effectively and efficiently, we guarantee you we can make your mass vac site faster and more efficient. And guess what? They were right. But shame on us in public sector if we're unwilling to take that offer. That's the kind of all-in Washington approach that we took to overturn every stone to be able to respond, and that's how we were successful.
I think that's a really good example of that. As long as Starbucks is not putting down names of people on cups or vaccines. So I've been called
I'm not going to comment on that one.
Exactly, sob or sad, etc. Sometimes that reflects the state of mind after I look at that. But other than that, no, it's leveraging it's the truly all hands on deck approach. So both of you are not only public health leaders, but are employers of folks that come out of the public health educational system. A lot of them from the schools of public health and medicine, etc., and nursing. What do you think if you had the choice of redesigning the skill set that people come out with from these programs that is relevant to not just a health department for applied public health, what would be your advice if you were given that opportunity? So maybe we can start with Dr. Juthani, and if you might want to add something there. And that's something for everyone, both faculty and others. Like, we need to be connected. We need to be responsive to the needs of health departments and the broader local and state public health.
So I think there's different types of roles in local health departments at the state level. So, for example, epidemiologists that deal with data, you maybe get very good training at learning how to analyze data, how to gather data, and be able to present it. I think some of the other skills that are really useful in health departments relate to project management, being able to provide deliverables, be able to present data more publicly, learning how to interface with policymakers and legislators. And I know there are different tracks in public health schools, and some public health schools are a little bit more research focused. Some public health schools are a little bit more hands-on in terms of getting those skills to be able to do jobs in public health. And some schools are sort of a mix of the two. And I think all public health schools are trying to train people to do all of the above. But I think being able to get some concrete skills in public speaking and presentation, analysis of data, and being able to communicate the value of the data that you're identifying, project management, to be able to say you've been given a task and be able to see it through, and be able to actually deal with the nitty-gritty on a lot of these things are some very technical skills. I think some of the other things that we see in our local health departments, for example, in Connecticut, local health departments do a lot of the environmental health safety. So whether this is on septic systems or sewer systems, whether you're doing food protection safety, which is another huge thing. You need scientific training. You need to have done science classes to actually be able to understand, why does temperature regulation of our food, like if we oversee restaurants and want to make sure that what they're serving is safe and that you don't get salmonella or something else when you go to eat in a given restaurant, well, why is that? And that scientific training is able to help prepare you for that. So there's really such a breadth of types of jobs that are available in public health, and getting skill sets in those various areas are the things that I would encourage people to think about, and think about what the end goal is, even if it's a first job right out of school, and what kinds of skills you might need to be able to prepare yourself best, and getting some of that experiential internship training to be able to prepare you for that type of job at the end.
And I'm going to have Tony give me a copy of our transformational plan. Thank you, Tony, my wonderful assistant who came from Houston to Washington. So really, thank you, Tony, for joining. So we recently launched our transformational plan in the fall of this last year, and I'm so excited about this transformational plan. It's built on our 3 cornerstone values of equity, innovation, engagement, has 5 areas of reflection, And one of the areas, we're the first state health agency in the nation to have Global in One Health as one of those 5. But another aspect, which is really exciting, in fact, just this week, we launched the recruitment for the leader of that area at our department, the first time ever that we're going to have a leader who's going to be leading Global in One Health together in our agency. Our second area is health systems and workforce transformation. And I just want to add to what Dr. Juthani said. And by the way, whenever she speaks, I always learn so much. There's wisdom that comes from being around her. And what I would say is the number one thing that we have, the number one challenge that we have in our field right now is our workforce. Hands down, our workforce is challenged. It is tired. It's ragged. It's been beaten up. It's been vilified. It's been attacked. It's been demonized. It's been caricaturized by a excuse my French here, bastardization of public health. So all the things that Dr. Juthani just mentioned, when you go into the popular media, when you go into a whole host of people asking about what public health is, or if you're going to try to explain it to your neighbor, they are not going to understand restaurant inspections or those other things. They're going to see the popular media of what the caricature of our field is. And what that means is that people have left our field. People have left our field, and people are going to continue to leave our field. In fact, the de Beaumont Foundation is saying that our field is going to see an exodus. A third of our workers, our field, is going to see in the next 5 years more people leaving, and a third have already left. Think about that. So when we talk about the skills that we need, it has to be people like you in this room and beyond thinking about how do we contribute to the future of public health. We know it's critical, but we've got to have that as part of it. The second piece is that there are so many skill sets that are not always taught in the theoretical classroom of public health schools or academia. We have to have real world experience that Dr. Juthani just mentioned. You have to know, you have to volunteer, you have to be a part of it, especially in emergencies, but also in blue sky days. You have to be a part of that to understand the skill sets. And then the final thing is a lot of the incorporation and embracing of other ways of looking at the world, whether it's debate and dialogue, how do we do that respectfully, but also forcefully and assertively. We should be willing to be able to take our field and respond in kind and a solidarity for our field. But the second piece of that is those skill sets in communications and engagement and policy making and, as I mentioned, debate and dialogue. These are skill sets that are oftentimes not taught in schools of public health in the same way that they should be. In fact, they're not even taught in medical school in the way that they should be. And so we have to do a better job with that.
Just to expand on it a little bit, Dr. Shah said that these are tough times for public health. So there are two kinds of people who run away from the fire and firefighters. You have to decide, are you going to run towards, are you a firefighter? Is that your calling? And I think that should be. That's the ethos of our profession in public health and medicine. And there's nothing more gratifying than to respond and the privilege to have the skills to be able to respond. So take that as a challenge. You're coming out of programs in public health, medicine, and nursing, and others, and take up that mantle and help redefine public health. Because I can tell you, on the other side, there's a lot of gratification. It's tough, but you will be your patients will be tested, but there is gratification. So we have people in this room who were at the beginning of the HIV epidemic. And they are some of the best role models that many of us have now. And I'm sure they did not know how it will end when they were in the thick of it in Brooklyn or other parts of New York or other places. But history will remember them really well. So with that, I will open up this forum for some questions from the audience. I have plenty of questions of my own, but would love to hear something from you. There are microphones there, so if you could raise your hands. I saw your hand first, so we'll go there first, and then we'll come here, number 2. And introduce yourself, and then you can ask your question.
Hi, thank you so much for your talk. I'm Natalia. I'm MPH first year student. So I want to flip the coin a little bit. You've talked about what you do at your local and state level departments. And it seems that even though the US healthcare system is such a strong and there's so much budget and there's so much going on, still it was very hard for the pandemic. So how are you sharing in any way this knowledge and preparedness to the global field? So how is this local knowledge translating into other countries or other similar, even states in the US? Thank you.
Thank you for that question. I thought you were going in a different direction. So maybe let me try to answer where I thought you were about to go, and then I'll try to answer your question specifically. I thought you were actually going into the healthcare system and the challenge within healthcare and public health. And so the underinvestment in public health is a real challenge that we have, a real concern. So for decades we've underinvested in public health, and then we have a pandemic, and why are our data systems not robust enough? Why is the workforce not able to do X, Y, or Z? Why is it that we don't have the right systems in place? Why do we not have health agencies that are robust enough to be able to respond? Well, it's because we've underinvested. These are policy choices that we've made when 96 cents on every dollar in the U.S. in health is spent in health care. And we've all, three of us as physicians, we have responded in the medical community. We know what that means, and we have incredible amount of respect for our medical community, but we know it's necessary but not sufficient. And that's where public health comes in. So now, that's where I thought you were going, but so that was, here's the question. So in our global and domestic health work and the envisioning that we're doing, it's very much about the bidirectionality. So oftentimes in the US, we have this hubris, right? We're going to take our ideas and we're going to send them out to the world because we have so much to teach the world. When in actuality, it's bidirectional. That we have so much to teach, yes, but we also have so much to learn, especially in resource-constrained environments that, by the way, they feel very much like everyday USA in many communities that are also resource-constrained. So one of the tenets of our global work is to actually learn from other nations and to then contribute back with those same opportunities in kind so we can change the landscape of learning across the system. And then Dr. Juthani, I know you and I are both with the Association of State and Territorial Health Officials, and we share across other states within the US, so maybe you can talk about that.
Yeah, thanks, Dr. Shah. I was just actually going to say that one of the reasons we know each other, and I learn so much from him regularly as well, is because of the national organization called the Association of State and Territorial Health Officials, where we meet every week, sometimes more than once a week, and really have the opportunity to learn from each other and leverage what one state is learning over another one and being able to operationalize that. And I think that camaraderie and group is a very unique group because there's 50 of us and then the territories who participate. But I totally echo your points on how we need to learn so much from what's happened globally as well. I think not having, one health system really in our country has made it difficult in many ways. So many things of the COVID response were done in many ways better in other countries. So I think we have a lot to learn, although we have a lot to also share with others.
And if I may plug your new office, or maybe you can sort of highlight that because I think it's very relevant to this question, because it's, I think, the first time a state health department is taking that initiative for having an Office of Global Health.
That's
within
right.
a state health department.
We're actually calling it OGO because we try to be a little bit, kind of swanky different. The Office of Global One, which I think is really cool, and it's an opportunity for us to really be thinking about just that. And so we're actively, as I mentioned, we're recruiting. This week we just launched. We're so excited about this, the recruitment for that leader. The real opportunity ultimately is to take multidisciplinary and interdisciplinary areas, global domestic health, One Health, right? Human health, animals, the environment. I always say entomology as well, insects. So don't forget mosquitoes, and Everybody forgets mosquitoes. I don't know why everybody forgets mosquitoes. Nobody in this room forgets mosquitoes, right? Okay, but a lot of people do. The intersection of all that, because that's truly what health is about. And then you throw in and remember the impact of climate and the changing environment. And so climate and health. And so it makes so much sense. And by the way, there's an incredible resonance, Dr. Umair, with tribes when you think about One Health. Because when our tribal leaders, they speak about many of the issues that are happening on their lands, they're very concerned about what's happening with the intersection of humans, animals, and the environment. So we're very excited about this. We think it's a path forward. So back to Dr. Juthani, the comment is, as we are launching these things, we want to be able to share with other states and other localities across the country. And that relationship, remember, we're very close to Canada. We're right next to Canada. And so we have a binational relationship with what's happening in Vancouver, or what's happening in the Northwest right across the border as well.
And this is very much the ethos of the Yale Institute for Global Health. We don't define global health in the context of geography. Our core value is that is health equity, that all lives are created equal. And populations' economic status doesn't have to dictate their health destiny. And so therefore, when you look at it from that perspective, it's not about here and there. It's not colonial or post-colonial, it's an orientation. It's about the shared humanity and the shared journey that we all have. And that when you start with that position, you arrive at these kinds of things where you say that all of us have to learn. For example, a community healthcare worker program is a very essential public health innovation that for once has some resources behind it. And we need to get that right. But one way we will get this right is by learning from our partners around the world who have done this reasonably well, not everywhere, but in more than enough places that there are sort of valuable lessons there. I'll come to you for the question.
And as you're going to the next question, I would just want to add, when we were vetting our transformational plan, we realized that there was obviously resonance of what was happening in some of the larger areas, but when we went to some of our rural areas, they said, immigrant populations and populations, agricultural farm workers or other aspects, or what's happening with our folks who are going overseas or back, there is resonance there as well with global and domestic health.
Thank you. I'm Larry Vitellano from the Child Study Center, Psychology and Psychiatry next door at the School of Medicine, professor there. So I wanted to ask you all what your thoughts are about this. We all are under pressure to kind of respond to the loudest voices. The loudest student in our class or the loudest patient. And so we all know that if we do that, we miss out on the quiet voices. And how do you think about that, and how do you defend against being worried about the loud voices who have a lot of power, or at least they think they do, and the quiet voices who feel they don't have the power? How do you do that, and how do you decide where to put the resources and efforts and not miss out? Thank you.
So I think some people are very good at advocating for themselves and their issues. Some groups are good at doing that. And sometimes they're good at doing that for the quiet. And I think the strength as a population is in community organizing and creating a synergy of people who can advocate for a given voice and a given topic so that your voice does become louder. Now, that doesn't answer your question on, so what do you do as somebody who's sitting on the other side? I guess I raise that because I do think what I see from where I am now is that it is true that the people who are able to organize and are able to get their message out and are able to come together do get their voice heard more. But there are many groups that have been successful at doing that for often voices that are not heard. So that's a credit to those people and those community members who've found a way Let's take gun violence as an example. You know, we have groups right here in New Haven, right in Hartford, that have organized, that have put themselves together, that are representing the grassroots. Whether you talk about HIV care, you know, there's so many different topics where you can get people who have shown that they've been able to make their voice more heard. I say on the side of somebody who's in state government now, I think when we try to address these topics that we recognize, because our job is really to recognize what are the public health problems that are really affecting our state. And when we do that, to have an open mind on who should be at the table, who should be reflecting their points, and to be open in the way that we bring those people to the table. And I think that I see that happening in state government, but I also would say that people who get the ear of their state legislator, so for anybody who has an issue, you know, talking to people who have that seat at the table already helps advance that point. A lot of people don't feel empowered to do that. Every single one of us has the right to contact a state representative, a state senator, and vote, quite frankly. These are the ways that we can exercise our agency on these things. But I do think it's on us to, and what I try to do is bring all those voices to the table anytime you're trying to address those big problems.
I would just add intentionality. We have to really be intentional in the process. And you know, Dr. Umair is an expert in this. I mean, this is an area where, you know, he has spent a lot of time with both researching but also advocating and articulating this publicly. And what I would say is the one thing that we'll remind ourselves is that we do hear from the extremes on both ends. And the vast majority of Americans, I believe, are in the middle. They're truly in the middle. They're worried about their kids going to school. They're worried about food on the table. They're worried about how their job. They're worried about the stress of everyday life. They're worried about tomorrow. That's the vast majority. And yet the loudest voices get the airplay. And that sucks the oxygen out of the room. And what the biggest challenge for us is to be intentional so we can also speak to both sides as well as understand and recognize what's happening in the middle.
So, although not intentional, but we find ourselves at this last global health conversation series event of the academic year with an all-minority panel, and in fact, for the first time, an all-South Asian panel. And so I think it will be, I'll take this opportunity, exactly. You won't find any of us calling that thing chai tea latte. It's chai. And so,
does everybody even understand? You might want to explain that one a
Yeah,
little bit
well,
more, yeah.
Well, so milk tea is chai. There's no latte. There's no milk. Milk tea. It's chai, and that's a hill I'm willing to die on. So coming back to that, coming back to the sort of to the main point, that of course leadership is often about sort of being the first in a room that hasn't seen someone who looks like you, or who has the same gender or sexual orientation, or the rural background, or first gen, or the underrepresented minority, or the immigrant background. And of course, there are fewer glass ceilings, but there are ceilings made of jello still there, that they put up resistance. And so therefore, they're often more nuanced and harder to navigate. So both of you are trailblazers from that aspect as well. And to put you on the spot a little bit, we get to do that in the academia. That's why God created tenure. I'll start
for
with
you, but not for us.
So maybe you can start, Dr. Shah, and then Dr. Juthani will end it with your thoughts on this. Something that lessons from being trailblazers.
I think the lesson that I take away is that yes, we're South Asian from a background standpoint, but it's more than that. That is where we come from. That's maybe our value, helped instill values. It's where our families, our ways of learning, how our parents raised us, our culture, our food, so much incredible, rich heritage. But ultimately, when you're in the work world, and when you're in the professional world, it's about competence. And we want to make sure that the people are good at what they do. And that is the ultimate number one thing. But we also recognize, to the earlier question about intentionality, when we are also looking to our workforce or to the next generation of leaders like all of you, we have to be intentional in making sure that we're also broad in our perspective and approach, so we also look like and start to mirror the very communities that we serve. And that has not always happened in this country. And that's why it's got to be an equity-based approach. And truly that is where leaders like us can bring that trail blazing, if that's what it's called. I really believe it's really the way we should operate and do our work.
So I think many people saw many South Asians at the forefront of the COVID pandemic on TV, in your hospitals, everywhere. And I see us as standing on the shoulders of giants, our parents and others who came before us that helped get us here. And I think in terms of being, the first or in these roles, these new roles that are more public facing, I view that as an honor, privilege, and obligation to be competent and to do the job well and to showcase for others that if I can do it, you can do it. That all of you who are in the room, you are students now. You were inspired by COVID. You were here because you wanted to be a firefighter, because you wanted to be at the forefront of addressing these concerns. And so I see that as our challenge and goal, is to inspire and show others that you too can do it, that you too can join this fight as we try to advocate for what's most important in health in our society and in our country.
Thank you. Really appreciate it. And it's a privilege to have you as guests for this conversation series. And thank you for coming. As you know, that this is a new era for public health. You all have to do, especially the students and early stage faculty, have to do better than us, than the current cohort, because there's no other choice. Because the next generation of challenges at the state, local, and global levels are existential. So the impact of global climate change, the fact that we have had a shrinkage in life expectancy in the richest country in the world, the fact that the city's map of COVID mortality looked like where brown and black people lived, that should be unacceptable. But we have the privilege of having the tools and being at institutions and having access to the knowledge and understanding to gear up for that struggle, that fight, if you will. So no pressure. Thank you.